Shall we start? Danielle, go ahead.
Yep, thank you, Shalini. Hello, everyone. Welcome to the UICC virtual dialogue on ensuring access to radiotherapy services. My name is Danielle Roden, and I'm a radiation oncologist at Princess Margaret Cancer Centre in Toronto and a member of the board of directors of UICC. And it's my pleasure to chair this session today. I'm fortunate to be joined by our distinguished panel, which includes Darian Montgomery from ICON, Anna Britton from Electa, Patrick Capellian from Varian, and Suharti Gonhovarjo from the National General Hospital in Indonesia. The goal of this dialogue is really to explore and discuss the role of radiotherapy in cancer control, some of the access challenges to radiotherapy, what some of the barriers are to that access, and importantly, thinking about some integrative and collaborative solutions to address it from a variety of different perspectives. The goal of the session is really to generate an open discussion among different stakeholders involved in radiotherapy services for cancer control, to share best practices and to help our cancer community navigate the challenges and urgency around access to radiotherapy globally. So we hope this session will be interactive. Please write any questions that you may have in the chat, and we will do our best to get to them. To start, I'd like to welcome our first speaker, Darian Montgomery. Darian has more than 20 years of experience as a radiation therapist and has worked in both public and private settings in New Zealand, Australia, and the UK. She has lectured at the University of Otago, New Zealand, and is a member of the New Zealand Targeting Cancer team, advocating the role of radiation therapy as a treatment option. She's also part of a working group that reports to a cancer agency in New Zealand. Most recently, she has taken on the role of radiotherapy news and online editor for the Journal of Medical Radiation Sciences, highlighting research undertaken by radiation therapists to enhance radiation therapy practice both locally and internationally. And in her daily work as site manager of ICON's New Zealand Centre, Darian manages a multidisciplinary team alongside physicians and ensuring clinical processes and operations run smoothly, enabling the team to deliver the best possible cancer care to patients. So Darian, I welcome, and I will turn the floor over to you.
Tēnā koutou katoa. Many thanks for that introduction, Danielle. It's my pleasure to be here today. I'd like to have the first slide, please. The global cancer burden is increasing, as we know, with cancer incidence increasing alongside an ageing population. And last year, we estimated that there were over 19 million new cases and 10 million deaths. And that's going to be increasing to over 30 million new cases and 17 million deaths by 2040. And this will be felt more so in low and middle income countries. 1 in 8 men and 1 in 11 women will die from cancer. But what this also tells us is that there are a large number of people that are going to be living with a cancer diagnosis. And while cancer control strategies have really focused on that screening and early prevention, radiotherapy hasn't always been at the forefront of those global conversations around cancer and the management, but radiotherapy has got a major role to play in the management for all of these patients. Next slide, please. So for those of us in the radiation oncology community, we know how vital radiation treatment is. 1 in 2 cancer patients worldwide would benefit from radiation treatment. 40% are curable with radiation treatment. And in the palliative setting, we know that it is equally effective in managing not just bone pain, but also symptomatic issues to improve quality of life for patients. And it has the potential to save over 1 million lives per year by 2035 if we can increase and close that gap. Next slide, please. Despite high initial costs, radiotherapy is a cost-effective treatment. Globally, cancer care costs around 5% of the national health expenditure, with radiotherapy contributing about 5% of those total cancer costs. The majority of those costs are taken up by access to drugs and inpatient stays, but yet only 30% of cancer patients currently receive radiation therapy. Next slide, please. And when we look at where we have access to radiation therapy, we can see that there is a real global inequity. Research undertaken by the Estro Hero project showed marked differences in the number of machines per million population, High-income countries have on average a median range of around 5 machines per million population, while those in lower and middle-income countries have a median range of around 1 to 5 machines. This is in stark contrast to on the African continent, where 27 countries have no access to radiation therapy at all. There are similar issues apparent in the Asia-Pacific region, where high-density populations need an increase in the number of machines to get to that median mark, but also need an increase in the number of staff to be able to support such an investment. And just to give you an idea of the scale required, it's around about 22,000 total machines needed by 2035, and approximately 7,700 new machines that are required to meet that demand by 2035. New slide, please. The barriers and challenges to accessing radiation therapy are numerous. And traditionally in low middle income countries, we think of poor equipment maintenance and not having robust quality control and safety measures in place when there are competing health and public development initiatives. High income countries are also not immune to some of these challenges and barriers. In New Zealand, with a population of 5 million, we have service fragmentation and variability of care. Our health system is largely publicly funded, with 24 machines across 6 public centres. Additionally, there are 4 private centres, and all of the new machines that have entered into the country in the last 10 years have been in private centres. As a geographically dispersed nation, the majority of patients do have to travel for radiation treatment. Both Australian and New Zealand studies have suggested that patients who live more than 100 kilometres away or are 2 hours away from the nearest radiation therapy centre are less likely to access care. And this has led to real variation in service across the country for our patients, with intervention rates of around 27% for our rural communities compared to 36% in more urban areas. Next slide. To be able to assess needs and gaps at a country or regional level, you do need data to ensure adequate planning of resources for both people and infrastructure. And globally, this can be really difficult as each country organises itself quite uniquely in terms of its roles and responsibilities, as well as thinking about the various socio-economic factors, cancer incidence, and the trajectory where a country may be in terms of technology rollout. The Estro Hero project looked at this across a number of European countries and demonstrated huge variations, not just in the number of machines per million population, but also in the number of radiation oncologists, radiation therapists, and medical physicists. The other challenge with data is that it is just a snapshot in time, and it doesn't account for the rapid evolution we see in radiation therapy, whether that be in the development of treatment techniques or like the rapid adoption of hyperfractionation that we've seen over the last 18 months of the global pandemic. Radiotherapy also requires a highly skilled workforce. This is an issue that all countries struggle with. In New Zealand, we have multiple vacancies across all disciplines, and our education providers can only support a limited number of placements at a given time. Increasing those placements puts additional strain and stress on an already stretched workforce. We have also seen organisations like the IEAE have spent considerable time and effort organising educational placements and fellowships for staff from low and middle income countries heading to high income countries, on the premise of those people going back to their countries to transfer those skills. But what we see is that there is sometimes that brain drain to high income countries, with these new skills being staying in the high income countries and those people taking those opportunities to further their careers abroad. And there is also a lot of inequity within populations. Health systems are designed in ways that don't always meet the individual needs at a patient level. Our Indigenous Maori population are 20 times more likely to experience cancer and twice as likely to die from cancer than New Zealand Europeans. Our health system hasn't recognised the unique holistic way in which Maori view the world, and this has really created a barrier not just in accessing radiation therapy treatment, but also health services in general. And we can see this affecting all minority groups. We need to have a culturally competent workforce that is diverse and mirrors the diversity we see in our communities, so that we can work in partnership to design, deliver, and monitor treatment with them so it is truly patient-centric. Next slide, please. These barriers and challenges will remain without significant investment across the board. Capital investment is needed for machines, but also for the infrastructure and building bunkers and supporting services, and also for capability and capacity building for our workforce. We need to ensure that those who make funding decisions about radiotherapy truly value it, with reimbursement policies that prioritise clinical benefit, drive technological innovation, and remove disincentives. We have tremendous leadership and advocacy within the radiation community, but there is still significant misinformation and fear. We need those in policy and decision-making roles to be engaged, to know that we exist, and that radiotherapy can improve cancer outcomes as part of an integrated cancer service solution. Next slide. And I'd like to finish with a Maori proverb. Mati whiri tahi ka whakatutukai ana pumanana e tangata. Radiotherapy needs a strong voice to improve access, and we all have a role to play in our countries, our communities, and within our social networks to advocate for increased access. It is only through this continued collaboration, cooperation, and connection that we can truly overcome the barriers and challenges. Thank you.
Thank you so much, Darian. Just a reminder to everyone, if you have questions, we'll do a Q&A at the end. So please, for everyone who's joined late, please share them in the chat. I'd now like to welcome our next speaker, Anna Britton. Anna is Director of Medical Affairs at Electa and Consultant Clinical Oncologist to the Sussex Cancer Centre. Her specialty training was at the Christie Hospital in Manchester, the Institut Gustave Roussy in Paris, and the Royal Marsden in London. She specializes in the treatment of patients with all types of lung cancer and prescribes radiotherapy as well as a range of systemic therapies. Her clinics are all in Worthing, but the radiotherapy is planned and delivered in Brighton. Her main interest is in developing radiotherapy services for the trust, and in particular, helping to implement advanced techniques such as stereotactic radiotherapy. Anna, I will turn it over to you.
Thank you very much. Thank you. Hello, everybody. So I've got a bit of a unique position. I work in industry 2 days a week and the NHS 3 days a week. And I've tried to keep this up very much to keep my clinical perspective, which hopefully helps Electa. So far, they haven't got rid of me, so they clearly think there's some benefit in it. Next slide, please. So I've been asked to sort of give a bit of an industry perspective. And I thought I would just simply divide it up into clinical challenges and technical challenges with regards to the implementation of radiotherapy in low middle income countries. So as we've already heard, there's obviously a large proportion of patients in low middle income countries who are not getting radiotherapy. And we all know that radiotherapy is cost effective, clinically effective, and just an essential part of the toolbox for cancer treatments. It spans the whole range, as we all know, so from the palliatives to the curative, and it can be repeated, and that's something that we don't say enough. Radiotherapy can be repeated, especially now we're learning more about stereotactic radiotherapy, repeatedly re-irradiating. It can be used in conjunction or concurrently with other treatments. So it is truly a Swiss knife of cancer treatment. Next slide, please. So for the clinical challenges, first of all, I think the couple of particular issues that I've thought of are, one, the education and training aspect. We obviously need to build the knowledge in those low middle income countries. And then there's the aspect of dealing with capacity, which working in the NHS, I'm faced with very much so. We have a real capacity issue as well. But with regards to the education and training and sort of building the knowledge, the ideal tools or solutions would be obviously these cloud-based applications that we have more and more of. Prono is one, but there are many others, which are all for which all you need really is an internet access, a stable internet access, which clearly I appreciate can be difficult in some countries. But that would allow a whole population of professionals to get up to speed in terms of radiation knowledge. It would allow obviously exchanges. So we're talking about sort of collaboration, mentoring, providing that sort of remote support for colleagues, friends, potentially who are just starting off on the radiotherapy sort of service development route. And we would, we've done this already in the high income countries. We'd be able to contour remotely, with plan would be optimized all remotely without having to be in the clinic. And COVID has, there's a silver lining to every cloud. COVID really helped us propagate that remote radiotherapy treatment, radiotherapy clinic. The telemedicine aspect has accelerated greatly thanks to COVID. So I'm doing a lot of remote clinics. Like this morning, I did a lung clinic remotely. We can do remote planning quite easily now. We can do peer-to-peer support, tumor boards. I just did an MDT remotely as well. But to be able to get that across to the low middle income countries shouldn't be too hard, as long as we've got that stable internet access, obviously. And then the dealing with capacity aspect, well, hyperfractionation in the UK, we've got a long history of it, and Canada, obviously. So that is the ideal way forward. There is very strong clinical evidence. We don't need to go back to the days of, 2-grade per fraction, standard fractionation. It's just a question, and the IEA completely endorses this, the hyperfractionation. The IEA is well on board about it. So it's about propagating that, and then encouraging the role diversification. We've got a real we've got a professional crisis on our hands. We don't have enough workforce in cancer generally. So particularly, we don't have enough radiation oncologists, we don't have enough medical physicists, radiographers. We're having to diversify our roles. We're having to do, for example, medics have to do less medic-y jobs, and then the radiographers and the medical physics are having to do more doctor jobs. It's a real mingling of skills now, and we need to facilitate that and promote it for these low middle income countries that are just starting. But there are obviously barriers, and this political, economic, social, technological, legal, environmental, it's not from me. I took it off the internet. Apparently every person who's done a business degree will know about these. So yes, unstable governments, the economic or the costs, the startup costs of radiotherapy, we all know are quite high. And then there's the maintenance costs, and that's a real worry for me, because this is technology that needs to be maintained. It may need spare parts. We have to think about the logistics. There are values and beliefs, that might prevent the implementation of radiotherapy in some countries, or may take a long time. People still talk about radiation or rays. They're thinking they're going to glow green. I still get that question. Oh, am I going to be a radioactive doctor? So there's a lot of cultural barriers that we need to also think about addressing. Connectivity, I mentioned already. And then there's the aspect of regulatory frameworks. I have not a clue about how things are in low middle income countries, but presumably that has to be done from scratch, getting the regulatory aspects all sorted out, because otherwise you can't implement. IRMA, making sure that there is someone who's IRMA trained on the ground. And then obviously this can't be done in a vacuum. We need to have the collaborations, the partnerships to facilitate this, which is not just governments, or hospitals or institutions or networks. Like we have cancer networks or cancer alliances in the UK. We may have to go towards sort of international cancer alliances. So having multiple institutions buddying up, franchises even. I know the MD Anderson has franchises, and the Christie Hospital has one franchise, I think, in Jordan. So lots of options to improve the standards everywhere and bring everyone up to the same standard, basically, and vendors, which is why I've been invited. Next slide, please. And then the technical challenges, which have similar barriers. You'll see that middle column's the same, but essentially, from the technical point of view, I think vendors like Elekta and Varian and others have created sort of low impact, low carbon footprint impact linacs, which are smaller, they fit into small bunkers, they're quick to install and commission. You have quick facilities like facial recognition, and QA, for example, daily QA normally done by a med-phys, a medical physicist, is now automated as much as possible. These LINACs, though they are small and compact, they have stereotactic capabilities, which is important for the hyperfractionation side. There are certain things that can be done remotely, for example, by an engineer. So there's remote LINAC maintenance. And then obviously on site, you might want to train up somebody, and this goes back to the sort of role diversification. You might need to train up a radiographer or a technician of some kind to do some very basic maintenance activities on the ground without having to call out an engineer from the next big city, fly them in, getting parts and that sort of thing. And then the technical aspects, the radiotherapy planning aspect is dealt with the in the cloud software solutions that are popping up left, right, and center. So the end-to-end radiotherapy planning is not an issue. I'm more worried about the engineering aspect, the sometimes essential maintenance aspect. And the dealing with capacity, well, that's just automation again. It's workflows, it's AI, it's deep learning, which we're doing in the West, and we'll be able to hopefully in the West and in high-income countries, and be able to sort of hand over to low middle-income countries without them having to go through all the steps, cobalt, etc. So the barriers are the same, I would say. Geography, transport networks may be an issue if you're thinking about, secondhand parts for LINACs, engineers having to come in to sort of sort out a LINAC. Should we be encouraging 2 LINAC institutions rather than single LINAC institutions so that you have sort of mirroring? One LINAC breaks down, you have the other LINAC, all that sort of thought process has to go in, and we, as people who already have the luxury of radiotherapy, should be able to help. And then again, the collaborations and interventions are much the same. It's about supporting as much as we possibly can. And that really is all I wanted to say. I mean, it's very simplistic. So thank you very much.
Dr. Britton, thank you very much for that really wonderful presentation. I'd now like to welcome our next speaker, Patrick Capellian, who is currently the VP of Medical Affairs at Varian Medical Systems. His responsibilities extend to various aspects, including regulatory feedback on product development, research and education, and cross-functional clinical support of all of our medical affairs initiatives. Prior to joining Varian, Dr. Capellian served as the Vice Chair of Clinical Operations and Clinical Research at UCLA, where he still has an appointment as Professor of Radiation Oncology. His academic career has included contributions in prostate radiotherapy with hyperfractionation and SBRT, and investigation of varied advanced image-guided radiotherapy techniques. Dr. Capellian completed his residency training in radiation oncology at the MD Anderson Cancer Center in Houston and fellowship at the Cleveland Clinic Foundation. He has authored more than 250 research papers, multiple review papers, and book chapters. He is board certified in radiation oncology and is a fellow of the American Society of Therapeutic Radiation and Oncology. Patrick, can I please turn this over to you?
Yes, hello. Hi, everyone. Very happy to be here. So could you advance the slide? Keep going. All right, so I'm not going to restate the problem. I think Darian and Anna did a great job essentially presenting the problem. So obviously we have many barriers to implementation, radiotherapy access and implementation throughout the world. And some of these problems are very common in resource-rich or resource deprived environments. Reimbursement is critical, but today I want to focus a little bit on some technological solutions and overall clinical readiness and clinical care quality, which are obviously related. Next slide. Next slide. So now Varian is part of a larger system, which is we're part of Siemens Healthineers in multiple countries. And so this comes up, the access to radiotherapy obviously is extremely important. The capabilities to take care of patients from diagnosis to throughout care has increased throughout the company. But what I wanted to do is maybe take some of the most challenging areas and talk about some of the progress that's been made, and highlight what our maybe thinking processes these days. So few years ago, we wouldn't been able to show maps where we have a number of countries that have actually access to radiotherapy. But what I wanted to highlight is that in some of these countries now they are pretty high-end capable radiotherapy groups and technologies that we can demonstrate that it's going to be feasible to implement high-quality care across very challenging areas. Next slide. Good evening. I think Anna already mentioned the issue of hyperfractionation. I think this is important because if you look at how much faster we can deliver radiation in ways that are better or at least have similar efficacy to conventional type of radiation courses, but increases convenience significantly, maybe even increases efficacy of treatment significantly. This is relevant everywhere. I would argue not just in low resource environment, but obviously less patient visits, easier patients to travel to radiation therapy centers, et cetera, becomes critically important. But all of this requires, to a large extent, higher level technologies, which in turn will require better training, better readiness to implement these types of treatments. Thanks. So specifically looking at technologies, there's been a lot of discussion about if we need specific technologies to these areas. I think the answer that we're getting to is probably not. First of all, we never want to give the impression that we're compromising quality care. Neither healthcare providers or patients don't want any kind of compromised care. And I think whatever technologies are implemented in high resource areas, healthcare providers and patients in those areas actually demand more or less the same. So in general, trying to make it very specific to those areas, technology implementation hasn't been necessarily that successful. And whatever is good for resource-deprived areas is good for resource-rich areas too. Reliability, robustness of these units, efficiency, versatility are very, very important. I think the appropriate clinical utilization of these of existing radiotherapy equipment is probably the most critical. Next. There are platforms. I think Anna mentioned that now we do have specific platforms. The one that we typically quote on variant side is the Halcyon platform. Very quick installation times, very high up times. And we have at least an example of a single center in India treating 180 plus patients a day. The treatment slot times are shrinking all the time. And most importantly, it's important to point out that some of these platforms can be upgradable to higher and higher capabilities. So it's important to have that angle explained well to these centers, that they are getting platforms that are either very capable to start with or can be upgradable. Next. And this is the example of a single machine that treated 180 plus patients in a center in India. And it's not low quality care. If you look at it, multiple anatomic sites delivering very high level of radiotherapy with image guidance, being able to shape the radiation field with IMRT, VMAT, et cetera. So there's no compromise in care in these situations. Next. Probably clinical readiness and just ensuring good clinical quality is probably the most important thing. So we spend a lot of time now thinking about the local resources and assessing the local resources, which is availability of specialized personnel, medical physicists, radiation therapists, their level of training, and adjusting the training that we open up to these centers and these individuals, either through the company resources or through collaborations or pointing in the right direction. It's critical, but that initial assessment of level of training is very important, and also provide clinical support whenever possible. So it's critical to also keep paying attention to the training and evaluation of the center moving forward, even after initial implementation. So if there are accreditation or certification programs available or possible, that's critical. A lot of times we like to see repeat training of the same personnel or training of new personnel that come into these departments, and gradually making sure they are able to implement newer and newer techniques. If it's technology specific techniques such as radiosurgery, all the way to implementation of, say, AI-based auto contouring, auto planning systems that are not always straightforward to use, but critical. So making sure that they understand how to utilize these technologies is critical. If we could do repeat site evaluations and not just a one-time visit and evaluation, that's critical. Ultimately, we would like to see all centers documenting their outcomes, and that ultimately opens up of the possibility to even do clinical research in these centers. Next. So in this context, we have a number of very hands-on courses that we offer to centers that are acquiring high-level technologies. This is an example of a course that we run in Cape Town in collaboration with the University of Cape Town. So again, collaboration, cooperation with clinical centers is critical. We have, a number of remote webinars. Obviously, this is important to be done with academic centers, and then even monthly training, treatment planning training sessions remotely with some collaborators. So all of these capabilities become critical, and it's just not a one-time thing. I think it's extremely important to keep repeating it and repeating it. Next. And finally, actually giving direct help on the ground becomes critical. So we've started thinking about oncology as a service, something that we could offer partners. And this is a busy slide, but there are a number of services that could be provided up front, how to set up, let's say, multidisciplinary tumor boards, or setting up decision support pathways, all the way to direct support of technology solutions. If it's tools to do virtual tumor boards, tools to help out with treatment planning, provide that as a service, give them counseling on multiple aspects, from things like billing to assessing resources, et cetera, et cetera. Next. And a couple of examples, next slide, please. And a couple of examples, for example, this is in Kenya, where we're directly supporting help with help in setting a cancer program that has elements of training and operational aspects. Next. And this one in Nigeria, where the direct support is in providing the support to do technology adoption, providing specific clinical services from treatment planning to QA, and gradually develop the services in that way. So I think these capabilities in a very practical way in these environments become critical. Next. So overall, I think we are a little bit in a different situation with these remote capabilities, with focus on assessing local resources, tailoring resources, and tailoring clinical training and support. So hopefully, with collaborations and cooperation, we can expand these capabilities. Thank you.
Thank you very much, Dr. Kapelian. I'd now like to welcome our final speaker from this panel, Dr. Sohartati Gondhawarjo, and she is coming from the Cipto National General Hospital in Jakarta, Indonesia. Tati is a radiation oncologist at the Cipto General Hospital in Jakarta. She is the chairperson of the National Cancer Control Committee, president of the Federation of Asian Organizations for Radiation Oncology, and president of the Indonesian Radiation Oncology Society. She's been actively involved in numerous activities related to cancer control in Indonesia for many years and participates in several oncology professional organizations. She is the past president of Southeast Asian Radiation Oncology Group, past president of the Indonesian Society of Oncology, and council member of the Asian Clinical Oncology Society. And she is the national project coordinator for several International Atomic Energy Agency projects. Dr. Tati, I will turn this over to you.
Thank you, Danielle, for your introduction. May I share my screen, please?
Yes, please.
Lorenzo, can you give
Co-host.
can you make Tati a co-host, please?
Yes.
I don't think I'm able to. It'll just be a moment, Tati. Sorry about this.
Yes, it's okay.
There you go. You should be in control now.
Yes, it's okay. Oh, sorry. Yeah, thank you very much. Good evening, everyone. Good day to all attendants in this meeting, wherever you are. First of all, I would like to thanks to the UICC team for inviting me in this very special event. I'm going to talk about the challenges and barrier to assessing radiotherapy and the need for integrative and collaborative approach from low middle income countries context and perspective. This is my overall outline for today. I begin with the situational analysis that I will move to explain about the radiotherapy success and access and profile in Asia, challenges and barriers that we are currently facing. And finally, I will share some Indonesian experience as one of the low middle income countries and propose solution to overcome the challenge and barrier. This is our global cancer incidence and mortality. Please note here that Asia, with the population of more than 60% of world population, present half of the global cancer incidence and even more for the mortality rate. The huge population of Asian country, which is more than 50% of the world population, should become the strength for our society, the Federation of Asian Radiation Oncology Society, as you know, FARO, as one of the radiation oncology society in our region. On the other side, Asia is also the most heterogeneous region. We can find a country with a very high income, but also a country with very low income. In regards to the radiotherapy, the Asian region has also the widest variability access to radiation treatment. Some has met even achieved beyond the IEA standard 1 million for 1 megavoltage, and some even still very far from reaching the standard. We will deeper discuss about this later. And the gap is also in the field of education and training, research and treatment planning and others. It is estimated increased burden of cancer of 2018 to 2040 is in line with the level of Human Development Index. We can see here that the low Human Development Index, the bigger increased burden for cancer. For example, we can see here 175, 62, 32% for low, medium, high, and very high Human Development Index, respectively. In Asia, the average is a bit higher than globally, 59 versus 56%. And here is the mapping of HDI level countries in our region, Asia. The darker is the higher HDI. And here is the list of the countries by level of HDI. The heterogeneity in development status as reflected by the GNI, gross national income per capita globally included in Asia country, is thought to influence the megavoltage machine number. Of course, the access of radiotherapy it is shown in this picture. Here's the comparison between the increased number of cancer patients need to be irradiated in year 2002-2012 versus the increased number of radiotherapy machine that's available. Only in high income countries, you can see here the increased number of machines is higher than what the need. So that's clear the gap between the, it become bigger and bigger as in upper and lower middle income countries, and also in low income countries. RTU, as you know, that the important factor when we try to calculate the need of radiotherapy within the country. So here, as here that the proportion of patients with cancer in whom EBRT is indicated during the journey of the disease was calculated average 50 to 52.3%. That means among 100 cancer patients, up to 50% will need to be irradiated. Which the most common cancer utilized radiotherapy was breast cancer, 87%. This is almost the same RTU data published 1 year after, also by Michael Barton, using the data from Australia. But if we analyze deeply this RTU data with cancer incident data, for example, from Indonesia as the one of the upper middle income countries, for the cancer case with the high utilization radiotherapy rate, for example, breast and cervical cancer are significantly higher in our country than in the data that analyzed by Michael Barton from the Australia. That means there is a possibility that the RTU in our country must be higher than what is published by Michael Barton. And I think it is also happened in other Asian countries. The coverage of radiotherapy in different income level from the publication of Zubi from the IEA with the interesting title, The Silence Crisis Continue. We can see that the RTU and mean fraction is different in every continent. And it is implies to the estimation of radiotherapy demand and supply. The coverage of radiotherapy using method megavoltage per million, so huge gap between low income, low middle income, and upper middle income, with advanced estimated only 40% for the low income, 30% for lower middle, and 51% for upper middle income countries. That's our data, looking deeper into the data from 14 FARO member countries. 18% of the Asia population is around 80% from the Asia population, based on the World Bank 2019 data and the latest 2021 radiotherapy surveys among FARO countries. From the population data, then the number of radiotherapy machine available in the country, then we can use the formula 1 megawatt per 1 million population. So 8 from 14 FARO member country has already achieved the 1 megawatt per 1 million population. And we can see here the best ratio is Japan, 1 megawatt for 1,035,000 people. But when we look for the using the important data, the cancer incidence and average global RTU, we take 50%. So which we will get a number of patients need to be irradiated. Using the calculation published by Zubi from IEA, written in the footnote, we can get the number of radiotherapy machine needed within the countries. And since that we have that number of radiotherapy available, we will get also the percentage coverage of radiotherapy equipment available from the need within the countries. From this data, we can see that no country has full coverage the need of radiotherapy equipment within the countries, whatever. The blue is the high income, the red is the upper middle, and the orange is the lower middle income countries. Moreover, grouping this data to the low, middle, upper middle income countries and high income countries, surprisingly that we can see that the low, middle, and upper middle income countries has the lower incidence of cancer per 1,000 population, 1 until 3 versus 7. And even with less cancer incidence data, the radiotherapy machine coverage in low, middle, and upper middle income countries has lower than in high income countries, 35 to 36 versus the 69%. And this discrepancy could be underestimate data of upper and low middle income country may be resulted from the unreliable cancer registry in upper and low middle income country, as well as the better awareness of cancer in high income countries for both public and medical professional, and also possible better medical service access. If we calculate it with the real cancer incidence, with the better and reliable cancer incidence, it is predicted that the coverage of radiotherapy in upper and lower middle income country maybe also will be far lower than what we have data here. On the other hand, any studies show that COVID-19 pandemic will have a severe negative effect on the global economy, including the growth of the radiotherapy services. The economic slowdown in the post-COVID-19 period could severely impact establishment of new radiotherapy facilities. And this is the situation in Indonesia. As you know that we already we are still going our best, still doing our best to expand access of radiotherapy. This is our availability right now. The blue area is the area have no access of radiotherapy service in this time. But then the end of next year, there are many new centers right now are still under ongoing process to provide radiotherapy service, including most important is the east part of Indonesia. You can see the things is already, the color is already changed. So we will geographically and all part of Indonesia, we have access for this treatment. And here is the growth of radiotherapy equipment in Indonesia chart from the 33 with a very low technology in 2010, and now we have almost 128. And if we do need analysis with hyperfractionated model, more than 8-hour working time, that means not the standard working time, we can see that the coverage of radiotherapy available in Indonesia is 30% and will become almost 50% at the end of next year. But we are still quite happy with that, since that based on our roadmap, we have a roadmap established in 2010, intend to escalate the radiotherapy service in our country stepwisely. But since that, we thought the increased number of machines should be in line with the increase of cancer awareness, the availability and rate of the implementation of national multidiscipline cancer guidelines within the country. So we have to be in line with the national cancer control program within the countries. Otherwise, it will become underutilized. So that's one reason why we have to have a roadmap how to fulfill the gap of radiotherapy service by period of time, geographic density, distance, based on our own data, capability, and demand. For example, with this roadmap for the 2035, totally it should be 240 machines in our country. How to sustain the development of radiotherapy in Indonesia? Our society has done several things, starting from the advocacy program to the national and local government engaged with the investor and private hospital, especially in terms of public-private partnership, as well as with the military healthcare system. Several points were emphasized in scaling up the radiotherapy in Indonesia. Those are radiotherapy is an essential part of the cancer management with the effective and cost efficient compared with other cancer treatment modality, and can improve the survival and quality of life. And last, will bring economic benefit to our country. And a review article we can see here by Mosa et al. States that the political stability and political will from the government is important for the radiotherapy growth. And the National Radiation Oncology Society is the key player and the game changer. There are two investment framework for the PPP, public partnership Indonesia to ask private sector, including the vendor, to invest in the field of radiotherapy service using the so-called the BOT and joint cooperation. We will discuss about this later. And the inequalities between radiotherapy, not only about the number of treatment machines. This is in this publication, they estimate, you can see here, 98% of both radiotherapy belongs to upper middle income countries and high income countries. In the human resource perspective, that's very important. There is also a huge gap in education training. In high income countries, graph A, in 2013, they have large training capacity and can have more than 80,000 radiation oncologists in next 2 years. 10 years. However, in low-income countries and low-middle-income countries, the total of radiation oncology training center is very limited. So they estimate only less than 2,000 radiation oncology available in the next 10 years. Is in next 10 years for the low-income countries. Now moving to the challenges, the biggest one we know is the health system barrier, namely the payment or insurance system. We asked our friends in our region about the availability of national health insurance in their countries, and the result is the majority of the countries in this part, 79%, in our region has already a national health insurance and covered the radiotherapy services. But I know that there are many problems with it. We also have many problems, but it's a good step toward universal health conference, and I hope that we can share more about this in the future. So here's what is the challenges, how to increase the radiotherapy services, increase number of radiotherapy as well as increase number of qualified human resources. The barrier, of course, from the government, lack of political will, private sectors, lack of investment commitment, and human resource capacity, lack of education and training centers, inequal distribution of human resources, especially in the countries like us, with more than 17,000 islands right now. So the solution is evidence-based advocacy. Radiation oncology has to be well presented in the National Cancer Control Committee and included in the National Cancer Control Program. Alignment of radiotherapy scale up with the universal health coverage or national insurance, and collaboration for the strategic advocacy and public-private partnership with the global agency and national NGOs and others. So as the take-home message, any countries need to calculate the need of radiotherapy equipment within their own countries and need to close the gap to increase the access of radiotherapy services, particularly in the low and middle income countries. Investment should not only focus on the radiotherapy equipment or infrastructure, but also educational and training. The solution, how to close the gap, cannot be generalized. It depends on the situation within the countries. Each countries have to have their own strategies. In this COVID-19 pandemic, there is acceleration and innovation in collaborative educational activities and training, and must make the best use of it. So thank you very much for your kind attention.
Thank you very much. We have a few minutes left for Q&A, so I'll just ask our speakers to please turn on your video and your microphone so we can address a couple of questions. One question came in, a couple of questions on really how to take advantage of setting of limited resources from Laura Idris. Asked, coming from Sudan, where they have more than 3,000 patients on their waiting list for radiotherapy and only 4 machines working for more than a 40 million population, looking for advice on how to maximize the benefit from available resources or to increase RT capacity. I think there were a number of suggestions that were identified in your talks. maybe in the last few minutes, would anyone like to go back and highlight a few points that were raised?
Maybe I can answer real quick. Having been to Sudan 2-3 times, I think specifically in Sudan, the interesting situation there is that actually there are a number of physics training programs, trained physicists and RTTs. So I would argue that specifically in Sudan, increasing the number of machines would go a long way. But with the existing, trained professionals over there, implementation of obviously shorter treatment courses would benefit a lot to actually increase the capacity on those machines. But I think that's the most obvious thing to say. Obviously, it's not enough machines for that kind of population, for sure.
Can I try to answer it?
Yeah, please.
Yeah. So what we do in our situation is, of course, first do the hyperfractionated scheme as much as possible, and then the second is to extend the working time using more shifts. Sometimes when our equipment, we have now 6 equipment, but when some of our equipment cannot work, so we do the shifting. So sometimes we work from the 7 to 12 o'clock in the middle of the night with 3 shifts. So the RTTs is shift, not first RTT 8 hours and the second and the third. So with that things, we can increase the number that can be treated a day. Thank you.
The other thing just to mention, because I prescribe drugs as well, is to work closely with your colleagues who prescribe chemotherapy. Chemotherapy can be very cheap, particularly platinum, and it works in a lot of cancers. So it's worth using chemotherapy as a bridging treatment.
And, we've talked a lot today about hypofractionation has come up in different, in some of the different presentations. A little while ago, prior to COVID, we had done a survey through Estro looking at uptake of hypofractionation and found that it was actually quite variable, particularly in a number of lower resource countries. I wonder if you can comment on some of what you perceive to be some of the barriers to hypofractionation uptake, and how maybe as a radiation oncology community, we can try to support that transition over to more appropriate use of hypofractionation.
All right, maybe I'll start again. Real quick. So there are certain diseases, for example, breast, where if you have the good enough equipment, the technique to actually do hypofractionation is not that difficult in a number of cases. I don't want to oversimplify what I'm saying, but there might be certain disease sites where it should be implemented as soon as possible. There are a number of reasons why people are afraid of hypofractionation, but I think a good review of the clinical literature, being comfortable with what exists out there and implementing it sooner rather than later actually makes a difference. There are certain things like lung, SBRT might be a little bit more difficult, but that's typically not the type of cases that low and middle income countries are facing early stage lung cancer necessarily. So it probably could be implemented relatively quickly.
There are lots of national guidelines, best practices, which we can, share. The NHS got them, everywhere's got them. So we're happy to sort of make that maybe freely available via portals like UICC or IAEA, which I'm sure IAEA has already got up there somewhere. So lots of best practice guidelines.
Well, yeah, last comment is that a lot of times the reimbursement systems, which are, payment by fraction doesn't help in this context.
Right. And Darian, you look like, Tati, sorry, go ahead.
Yeah, in that situation, in the low and middle income countries, especially in low, middle, and low income countries, actually there are more palliative treatment. Low, locally advanced and advanced cases that we give the radiotherapy just only for palliation. In that situation, we can easily doing the hyperfractionated scheme.
Right.
So
so
the
we are-
important thing is we can increase the number of patients that can be treated. Thank you.
Right. No, I think those are all great points. We are now up at the hour. I'd like to make a note. There was a comment or a question that came in from Tajikistan and Central Asia around how many radiotherapy devices should work to decrease the gap in access in that country. Maybe I can ask, just given the time, this speaker to follow up directly with our panelists. I think, you know, that's quite a technical question, and I think maybe could be addressed well offline. So given the time, I'd like to thank everyone for joining us this morning here in Canada, or whatever time of day around the world. It's been a great discussion, and look forward to seeing you all at the next virtual dialogue. Thanks very much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.